you cannot take. And non-unions, again, there are two types, two or three types: infected non-unions, non-infected non-unions, vascular non-unions, and avascular non-unions. So atrophic non-union is vascular non-union, vascular non-union. So there are certain limitations, but the people are using ultrasound, but it takes a long time. So, but you should know the methods. But you should know methods for the completion sake. We are knowing the methods. Yes. So there is something called conduction, convection, and conversion. So here, ultrasound is a deep therapy where there is activities of conversion. What is that conversion? Ultrasound is a waves, echogenic waves. The waves are converting, the sound waves you are converting into heat waves. Adi point two. So that is also basic principle.
Yes.
Yeah.
Morning, sir. Morning, sir.
Just start.
Shall I start?
No, sir.
So, okay, sir.
9. Time is 9. Okay, sir. Start, sir, please.
Okay, good morning, everyone. Today's topic is low-intensity pulsed ultrasound in the treatment of non-unions and fresh fractures. It is a case series done in Italy in the year 2022, sir. So, sir, trauma care, sir. Yes, sir. Italy. It was done in Italy. It is collected from a group of hospitals, the similar cases. So this is a recent advancement and also given in the recent text. No, sir. No, sir. Treated with this, no, sir. No, sir. I searched for it, sir. I didn't find a particular. Regarding the ultrasound and all, I didn't find, so just. This is a generalized study, sir. This includes both with implant and without implant. So.
No, with implant, that is also point. With implant, do you want to use the MRI? Do you want to use the ultrasound? Or do you want to use the other modality?
Depending upon the metal, we can.
Suppose the metal is there. Do you use ultrasound? You don't use the ultrasound.
It's better to use ultrasound than.
Can you use MRI with the metal in situ?
Particularly if titanium and all, we can use.
Titanium, other things, 316L, you should not use. Very good point, sir. Well taken. Yes, sir.
So, introduction. Coming to the introduction, the incidence of fracture non-union is estimated to be between 5% and 10%. The risk of non-union is related to several factors, including fracture severity, localization, comorbidities, and other medication use. The medication use includes the ibuprofen and other NSAIDs. Surgical management of non-unions has a large socioeconomic impact on both patients and healthcare system. The success rate of surgical treatment of non-unions is between 70% and 90%, depending on fracture location and also the surgical technique. So non-unions will still represent a challenge in clinical practice and are associated with an increased risk of further complications. So the low-intensity pulsed ultrasound, which is LIPUS, is a non-invasive therapy widely used within the orthopedic community to accelerate the healing of fresh fractures and also to minimize the delayed healing and to stimulate the healing of non-unions. Specific ultrasound signal characteristics and treatment regimens have been reported to significantly enhance the fracture healing process. LIPUS is widely recommended as a standalone or adjuvant therapy, adjuvant treatment for non-unions, delayed unions, and also the fresh fractures. In the last 20 years, data in the literature support the efficacy of LIPUS in all types of fractures. The use of physical stimuli to enhance the reparative osteogenesis have been widely investigated, and its clinical use is based on sound scientific evidence. Coming to the aims of the study. So, electric stimulation is and also so both both yeah. So these work by the principle of stimulation of the neurotransmitters, which promotes the angiogenesis and all. And yes, sir, I have kept the physiology for this. So coming to the aims of the study series is to evaluate the most frequently lipus treated sites, the average stimulation time for fresh fractures and non-unions, the average healing time for fresh fractures and non-unions treated with lipus, the healing rate of non-unions and fresh fractures treated with lipus, and the patient compliance for lipus. And the materials and methods. A total of 65 patients were analyzed, 46 males and 19 females. 46 non-unions and 19 fresh fractures were treated with lipus for at least a period of 3 months or until fracture healing, whichever came first. All age groups were included in this, and the exclusion criteria are fractures not adequately stabilized. Fractures not adequately stabilized or aligned, and also the fractures with bone gap bigger than half their bone diameter.
That is a point. And one more thing is atrophic non-unions. Atrophic non-unions, high BMI, body mass index, infected non-unions.
These are kept in exclusion.
Exclusion, so you cannot cover this. So most of the time ultrasound works well, and the gap between the bone gap less than 1 centimeter, more than 1 centimeter. If the gap is more gap non-unions, no role, exclusion never comes.
Sir? If they are stable, sir. Sir, if there is delay healing, we can try this as an adjuvant therapy. Yes, sir. Yes, sir, they have done, sir, for both non-union and fresh fractures.
Ideally, do you advise in non-unions or delayed unions?
It's better to use in delayed unions than non-unions.
No. The ultrasound therapy is
yes, sir,
better.
It is.
Delayed union is better, non-unions is better.
It is better to use in delayed unions than in non-unions.
That is a point. That point should be taken. Yes, sir. Go ahead. So that's why I said fresh fractures. Use the word fresh fractures. Very good, sir. Yes.
So coming to the mechanism of action, there is a role for integrins, which is a protein. So it's a mesenchymal surface protein, which helps in the formation of focal adhesions on the surface of lipus-stimulated cells. The group at the Manchester showed that lipus was able to cause the formation of focal adhesions in the absence of syndican 4. Syndican 4 is also a protein which helps in formation of adhesions, which are the requirement for the formation of focal adhesions in all other systems. Syndicans are type 1 transmembrane proteins with a core protein modified with glycase aminoglycan chains. Expression of syndican 4 is upregulated in fibroblast and endothelial cells following dermal injury. And the closure of dermal wounds is delayed in syndican 4 knockout mouse and forms hypertrophic non-unions when the bones are fractured. I'll explain the diagram after the next slide, sir.
Pointer can take this.
Yeah, it's okay, sir.
Yeah, show the point.
I will explain this in the next slide, sir, after completing this.
Yeah.
So a pathway linking the formation of focal adhesions to the GTPase. GTPase is usually enzyme which helps in promotion of the neurotransmitters, which helps in healing process by increasing the blood supply at the injury site. And also the RAC1 has been identified. RAC1 plays an important role. RAC is like ROS-related C3 botulinum toxin, which is also a neurotransmitter which helps in the healing process. So RAC1 was central to the effect of lipus, and that pharmaceutical blockage of RAC1 signaling could nullify the effects of lipus in an animal model in which lipus was demonstrated to accelerate healing. The current working hypothesis is that there are two pathways to activate the RAC1 in order to get the healing: the traditional way and through using the LIPers. The nanomotion stimulated by LIPers is detected by cells using the surface receptors, which is integrins, which convert the mechanical wave into biological signaling, resulting in number of growth factors such as the bone morphogenetic proteins, transforming growth factor beta and also vascular endothelial growth factor to be significantly enhanced in the fractures. So LIPers not only increases growth factors local to the fracture and increase the vascularization, but also can positively enhance the number of CXCR4 positive mesenchymal cells holding to the fracture site. CXCR4 is CXC chemokinase substrate receptor. Sir. In the early development, CXCR4 aids in the cellular migration, whereas in adults it helps in signaling. This signaling helps stem cells to migrate to the bone from the bone marrow to repair the damaged tissue. Thus, lupus can signal through the alternative pathways to achieve the fracture healing. One is through the conventional method. Other method is using, coming to the RA7 activation and GTP. So this is through the normal extracellular matrix method, and this is through the LIPers. Both activate the integrin, which further activates the PKC and various factors like guanine nucleotide exchange factors, and ultimately leading to the activation of RAC1 and GTP. Induction. Osteoinduction. Induction.
What is RAC?
RAC is ROS-related C3 botulinum toxin, sir.
So what is its significance?
So it increases it activates as a neurotransmitter and further enhances the production of VEGF and other biochemical substances which promotes the bone.
So it converts the mechanical into biological. Very
yes,
good
sir.
point. Yes, sir.
So these are the various roles of ultrasonography in healing process. It also helps in muscle injury, recovering of muscle injury by promoting the muscle regeneration and also the enhancing angiogenesis, and also modulate the inflammation. It inhibits the fibrosis, which prevents in formation of strictures and contractures. Yes, in various, in also in tendinopathies, muscle repair, joint capsule diseases, and also cartilage injury. So coming to the LIPers treatment protocol, to apply LIPers, these people from Italy, they have used a fast device. No, sir. Sir? No, sir, I haven't inquired. I just took the journal, sir. To apply LIPers, the fast device is used for this case series. This medical device delivers an ultrasound signal composed of a burst width of 200 microseconds containing 1.5 millihertz sine waves with a repetition rate of 1 kilohertz and delivers.
It is a millihertz or megahertz?
Milli, sir.
Sure.
Sure. Chusna. Manual Chusna. So with the repetition rate of 1 kilohertz and delivers 30 microwatts per square centimeters of a spatial averaged and temporal averaged intensity. The therapeutic signal generated by the device is delivered through a transducer positioned on the skin overlying the fracture with an ultrasound coupling gel. Sir. Yes, sir. After immobilization, after stabilizing the fracture, we have to. So if we applied a cast, we can make a window over it and we can place the transducer. Yes, sir. Yes, sir. It has to be in contact with the skin. So this is a transducer. We will apply the gel to it, and it has to be in contact with the skin surface. It has to be kept for around 20 minutes for a period of 3 months. It costs around $2,500 in the US. I don't know. I haven't inquired about the product in Indian markets. So yeah, I said 20 minutes. So treatment time was around 20 minutes per day with a warning signal that sounded if there was no proper coupling to the skin. The operating unit contained an integrated timer that monitored treatment times and automatically turned the unit off after 20 minutes of daily treatment. A visual and audible signal alerted the patient that treatment was completed. Patients were instructed on the use of device and performed the treatment at home. Treatment was continued for at least 3 months or until the fracture healing, whichever came first. Bone healing was assessed both at the radiological and functional level. And radiological healing was defined by the presence of bridging callus on radiographs in 3 out of the 4 cortices. And clinical healing was defined by the absence of pain at the fracture site. The need for further surgery or persistence of non-union were considered in treatment failures. And also in the post-operative cases, if the person is having a plate of one of the forearm bone, the ideal site, sir, whatever it is. So for plating, we have to keep it opposite to the surgical site. We can't keep the instrument directly on the plates. We have to keep it in the opposite side. But there is no such regulations for nail as it is inside the bone. So there is no such restrictions. Yes, sir. Yes, sir. We can keep it at any surface, sir. There is no such restriction. Yes, sir, they have mentioned, but I haven't kept this. The thing which I have said now as written in the manual, sir, of that.
Okay, come to the point. So the clinical union is early or radiological union is early?
So clinical will be presented first, sir, and later after a period of 3 months or 2 months, radiological.
So the clinical union is early.
Yes, sir.
Radiological union is late.
Yes, sir.
So you have to assess both the clinical, radiological, and
yes,
functional
sir.
activities.
Yes, sir. Functional.
So okay.
So pathogenesis of non-union, where the inflammation increases, osteogenesis of the mesenchymal stem cells will be reduced, and BMPs versus the antagonist imbalance will be there, and nitric oxide signaling will be reduced, which promotes the angiogenesis and heals the and promotes the bone growth, and angiogenesis will be reduced, and WNT signaling and ecstasy. So WNT has no full form. It helps in molecular pathway that regulates cell renewal and apoptosis and yes, sir. I haven't gone through it. Yes, I will. Yes. And also nitric oxide signaling promotes the phagocytic and reduces inflammation, and also increases the blood flow. And possible effects of lupus includes reduces inflammation and promotes the BMP, which helps in osteogenesis of the mesenchymal stem cells, and also BMP and increases the BMP and BMP receptors. And NVO signaling will be increased, angiogenesis will be increased, and WNT signaling will be increased, and also the extracellular matrix remodeling will be increased. Coming to the results, we have taken 46 cases of non-union, and also 19 cases of fresh fractures. 19 of them were upper limb. Sir, this is a non-union case, sir. Established non-union case. So 19 cases were taken for upper limb and 27 for the lower limb, and the mean age is 44 plus or minus 18 years. And the average time between the fracture and the lupus therapy was around 14 months. The average time between the last surgery and the lupus therapy was 83 plus or minus 165 days. And the average treatment time was around 100 plus or minus 72 days. And 60% of the patients has completed around 75% of their sessions, which is around 2 to 2.5 months. And 89% of the non-unions healed within 89 plus or minus 53 days. Whereas coming to the fresh fractures has better results. There you can see them 70% of patients have completed 70% of sessions, and 95% of the fresh fractures healed within a period of 46 plus or minus 28 days. With immobilization, sir. So if it is a stable fracture, we can keep it as an adjuvant therapy, sir. Obviously it will heal, yes, sir. Yes, sir. For that, it has to be a stable fracture. So no adverse events related to the use of device were recorded, even in the presence of metal implants, plates, screws or nails, or any other infections. And 5 patients who have not healed had an average 2 prior surgeries, and 4 out of 5 patients were smokers. and bone loss was present in 3 patients suffering from non-unions. 2 patients had infected non-unions and 2 patients required further surgery. So there was no statistically significant difference in healing rate achieved in non-unions treated either conservatively or surgically before the LIPUS stimulations. No discrimination, both are same. So here's the percentage of healing in non-unions and in fresh fractures. The non-union healing rate is around 89.1%, whereas in fresh fractures it is around 95%. There is no so much difference. There is one more case of non-union, whereas a 57-year-old male with post-traumatic non-union of forearm. Sir. Yes, sir, this was in the article. Post-traumatic non-union of the forearm treated with plates, and which is followed by Elizarov treatment for 6.5 months, and lengthening of radius and compression at the level of non-union was done. And started the LIPUS treatment, and is continued for around 60 days. There is a gap over. Yes, sir, to enhance it. For a period, there is no such, there is delayed union, sir, so they have done, they have tried it as an adjuvant therapy. Sir. Sir, actually, they used it as a supportive treatment, not as a single source of treatment, sir. So combinedly, it has helped the patient.
Adjuvant.
Might be.
So the basic principle.
Actually, the drawback of this study is the same thing, sir. They haven't compared the cases, people who are using this and people who haven't used this. That's a drawback of this. So clinical healing with the restoration of forearm length, normal distal radius and ulnar ratios, and also the wrist function. You can see the attainment of normal. Yes, sir. Yeah. So coming to the discussion, 5 to 10% of the fractures may evolve into non-unions, and factors like soft tissue damage and open comminuted fractures could lead to an increased risk of non-unions or delayed unions. It was reported that non-unions occurred in 4.7% of distal femoral fractures and 2.8% of the shaft femoral fractures. To enhance the healing process and therapeutic strategies, including the mechanical environmental control, use of growth factors and cell therapies showed convincing results. And recently, pharmacological systemic treatment with teriparatide, which is a synthetic parathyroid hormone, was suggested to favor bone healing in case of non-unions. And also, we have been using BMAC as a bone marrow aspirate concentrate as a treatment for non-union cases. In addition to orthobiologics and pharmacological treatments, therapies based on physical stimuli are increasingly gaining importance in orthopedic and traumatology practice. The first report describing the possibility of promoting osteogenesis with physical stimuli such as ultrasound dates back in 1953, when Carodi and Cosolino showed the accelerated bone healing of fresh fractures in the rapid radius compared to control. And Heckman et al. Studied LIPUS for simple closed or Gustula-Anderson type 1 open tibial shaft fractures immobilized by cast, and show statistically significant improvements in the time of clinical healing to overall healing, and also in the proportion of fractures healed within 120 days, whereas LIPUS 88% and 44% control, and proportion of fractures healed within 150 days in LIPUS has a healing rate of 94% and control has 62%. And Leung et al. In a randomized placebo-controlled clinical trial on open or severely comminuted tibial shaft fractures immobilized by intramedullary nailing or external fixation showed that LIPUS stimulation accelerates full weight bearing and bone callus formation by 40% compared to the control group. And finally, Zura et al. Reported in the largest cohort of chronic non-union patients treated with LIPUS, a healing rate of 86.2% in fractures that failed to heal for at least 1 year before treatment. This data suggests that LIPUS stimulation might mitigate the presence of fracture characteristics associated with an increased risk of healing failure. LIPUS treatment proved to be safe, valuable, economically viable clinical option as an alternative to revision surgery for established non-union in foot and ankle. The healing rates reported in this study are in line with previous reports showing. Sir. It's no, sir. I don't think it is. I have to. I'll inquire, sir. Sir. Okay, the healing rates reported in the study are in line with previous reports showing an overall success rate greater than 80% for lipos therapy in the treatment of non-unions, which is comparable with the success rate achieved with surgical management of uninfected non-unions. And as far as the fresh fractures are concerned, lipos has been proved in the literature to be able to shorten the time of non-union as well as to decrease the chance of delayed unions. 95% of the fresh fractures healed with an average healing time of 46 days, regardless of the presence of risk factors such as smoking or diabetes. And coming to the limitations, the main limitation of this case series is lack of untreated controls and also the absence of blinding. Both the patients and clinicians were aware of this type of treatment. It might affect the review of this case study, sir. And also the conclusion. The multi-center clinical experience here reported indicates that lipos therapy should be considered as a low-risk option, both as an adjunct to surgery as a standalone therapy in the management of non-unions and fresh fractures. No, sir. They have given only one case in that. Nothing, sir. They haven't mentioned. They just mentioned the data about the success ratios of it, but they haven't proved it significant. Yeah. Yes, sir. Yes, sir. No, sir. In that thing, they haven't mentioned any. The only picture which I got is this. Only one picture they have. Mm. Yes, sir. It's proof, yeah, sir. Yes, sir. Just to be functionally stable. Yes, sir. Yes, sir. Yes, sir. Yes, sir. They have to show in the pictures. They haven't shown.
And another thing is you have shown the Elizaro and low intensity ultrasound. The basic function of Elizaro is
To promote the reduce
distraction
the graph.
osteogenesis. Distraction osteogenesis.
Yes. Sir. Sir. Yes, sir. It is from it. Trauma care. లేదు సార్ ఇది జస్ట్ అక్కడి నుంచి తీసుకున్నాను.
It's already surgically stabilized. It is already surgically stabilized, and it is something like adjuvant.
Yes, sir. It's
Not much importance. And you said it is
I'll do.
And you said
I'll find out the price of. It's too much for the Indian scenario.
And it is a 20 years. You said 20 years studies on different hospitals.
Yes.
So
Recently also they asked. Yeah.
I think that point is important for
Yes.
exam purposes. Very good.
Thanks.
Good morning, sir. These are cases done in Unit 1. 24 years male with 1 month old, closed middle third both bone sharp fracture of left forearm, sir. For this, we have done open reduction internal fixation with plating for both ulna and radius. No graft. We on intraoperatively yes, sir, 1 month old. We removed freshened the edges, and we thought that the alignment is normal and no shortening of the. Yes, sir. No apparent shortening of the bones. Sclerosis. sclerosis. Yeah, we have debrided and till the yes. 50 years female sir with intertrochanteric fracture of left femur. For this, close reduction internal fixation with proximal femoral nail for left femur. This is 60 years female sir with subtrochanteric fracture of right femur. This is 3 weeks old case sir. Actually first we have kept this case in traction table, but we didn't achieve compression, but so we converted it into supine position with open reduction internal fixation with long PFM. Sir, due to osteoporosis. Yes. Yes. 62 years male sir with fracture neck of fifth metacarpal of left hand, boxer's fracture. We have done percutaneous spinning with K-wire fixations. (60 years male sir with distal interpharyngeal joint dislocation of the left thumb. For this we have done percutaneous with K-wire fixation. We have tried sir, but it's not reduced in cash. No. RAS. 52 years male sir with grade 2 compound fourth middle phalanx fracture of right foot sir. For this we have done percutaneous spinning with K-wire fixation for middle phalanx and neck of the fourth metatarsal. No dislocations. Fracture is also there, the oblique view in the middle phalanx sir. Sir, normals. Normals. Sir? Actually, we can metatarsophalangeal joints. You are asking. It is very hard to try in casualty, sir. We can give a try, but if it is not, we should open it and give. Due to the interposition of the capsule and the extensor tendons in the metatarsophalangeal joints. (11 years male sir with 4 weeks old closed middle third shaft fracture of both bone of right leg sir. We have done close reduction internal fixation with tense nailing. 1 month old sir. Yes sir. No sir, actually cast was applied when the patient came sir, but this is the extra. Yes. 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 We tried in OTs. Yes. We have now sir, actually under anesthesia we have also tried by manipulation sir. It didn't get. This is a case done last week sir. 70 years female came, sir, with the chief complaint of swelling over the lateral aspect of the left knee. She came with the chief complaint of the swelling over the lateral aspect of the left knee and also on the ulnar aspect of the right elbow, sir, since 4 months. And she has only mild pain while walking, and she had a history of TB 13 years back. On examination, no, range of movements were normal. Soft cystic swelling, lobular swelling is seen, sir, and it is not adherent to the bone, and it is movable, sir. Skin is pinchable over the surface of the swelling, sir. And first we have thought it was a tumor calcinosis, sir. First we have to follow the investigations. Softest, but yes, sir. Bursitis. Yes, sir. And yes, sir. And any benign tumors. Yes, sir. No, sir. First, no, yes, sir. Features of bursitis, clinical features of bursitis and exam is not there, sir. There is no fever, no local rise of temperature, and no elevated CRP and ESR levels, sir. Yes. Yes, sir. Yes. We have followed regular investigations, and in that serum calcium and phosphorus were normal, and ultrasound revealed tumor cystic swelling of. These are the clinical range of movements, sir, and this elbow one. And in ultrasound, it revealed likely bursitis features with the pre-patellar bursitis over the aspect left knee. Yes, sir. These are ultrasound and these are MRI films. And MRI, they have showed fluid collection with other features in revealing complete tear of the lateral patellofemoral ligament and others. Yes, sir. ACL rupture. Yes, sir. Only the patellofemoral ligament is injured. It is confined to the bursa, sir. Pre-patellar bursa. Yes, sir. No, sir. Yes, sir. The bursite the sac may have, with the increased inflammation, the sac may have Yes, sir. Yes, sir. It is prepatellar bursa over the subcutaneous knee. Yes, sir. Deviate to laterals. Yes. These are MRI reports. Serum calcium and phosphorus were normal, sir. So initially we thought this might be tumor calcinosis, but intraoperatively we thought on a incision pus flowed out, and we have excised the bursal sac.
So what we made a mistake is would have directly put a needle and would have found this only
Yes,
abscess. So that means a bursa can undergo many changes. So what are the changes a bursa can undergo? Bursa can undergo changes normally. What are the changes? That is one of the changes is this abscess formation, hematoma, calcification, then transformation into a
May transform into malignancy.
So
And
you
may
think
involve
always bursa is
joints.
there, long duration bursa which is there. You have to think of all the complications. So what is bursa?
Is a structure which acts as a cushion while performing
Cushion.
movements.
It's a sac lined by
Sac.
epithelium. Wherever there is origin or insertion of this they get this, or the pressure points can get this, which is bursa. That gets inflamed, sometimes produce a hematoma or calcified hematoma or infection like this, what you have a abscess there. Sometimes malignancy.
Yes, sir.
All things are there possible. So what we have missed is that only. We
Yes,
have
sir.
not put the needle, we thought something else with a great, diagnosis of tumoral calcinosis, which doesn't fit in this now. Right.
So the points to be remembered is it might be bursitis, or it might be tumor calcinosis, or it might be myositis ossificans, and benign and malignant soft tissue tumors, or it might be osteosarcoma or synovial osteochondromatosis. Thank you. Yes, yes, sir. Pus for culture sensitivity center. Yes, sir. It is also report is yet to come, sir. No, sir. Because it is not involving the synovial joint, sir. It is the sac is outside the, not communicating with the joint. Yes. Yes.
Good morning, sir. These are cases done in Unit 3. 65-year male with 1 year 3 months old proximal third shaft fracture of right femur with implant failure. Because
Improper
What?
fixation. Fixation is good only. First exercise means before the surgery. Before surgery.
no,
Before surgery, then you can make out
This
first and
one.
first. Where
this one, sir.
is that?
Yes, sir.
Zoom jai. The problem is this only. Combination fragment is there, big fragment which has gone. That's what it has not taken up. Right. Fixation is good. Only thing is combination is there a lot. It has must have failed. That's all. With the mechanical failure or attempted union is there.
Yes, sir. Attempted unit.
Fracture failure or the mechanical failure. Is it?
He has a history of assault, sir.
ऐसे में तो मसाज आते हैं. You'll get again. Did he fall again? Yes. Right. Okay. How many months is surgery done ago? For
1
1
year
year.
3 months.
He was working with that
Yes, he was working.
after surgery.
With Walker, he was working.
Okay. Mm-hmm. Right. So, what have we done for this?
Sir, we had done implant removal and open reduction internal fixation with long PFN and 10 hole recon plates.
Same PF we have used or
No, sir.
some size. Right. Mm-hmm. What about the plates you have put? Augmentation of the plate? Plate is there.
Yes, sir. Recon plates, sir.
Where? On the lateral medial side.
Lateral sets.
No, asal surgery.
No, sir.
Is on lateral side, medial side.
Lateral, sir.
So what about medial side? That's what I said. Medial side, they have to document more. Graft is medial side. They put graft.
No graft, sir. Callus formation, that one.
Go on.
Medial side are augmented more with lot of graft.
Revision. Priya, show me the. This is post-op.
Post-ups.
So what was the reason why the nail is broken?
History of fall is there, sir. 3 months ago.
Fall. When was it done?
1 year back, sir.
1 year back. Was it joined or not joined?
Joints.
You think it was joined? Okay, any X-ray? Oh, this is joined already. This was taken on 12th June. Oh, same. What's up? You know. July, June. No, it's not joined. Okay, go back. Forward. One.
This one.
This one. So generally, what is the indication? What was the type of fall?
Trivial fall, sir. It
Huh?
is.
Trivial fall.
Yes, sir.
So what happens? This one is broken means what is the indication? It's broken before. Yeah. So what is the indication? Why implant fails? We discussed last time. Yes. That's the bottom line. So it's failed after 1 year with a trivial fall means there is no union. That's the reason. See, excess callus is there. That means there is a mobility at the fracture. Generally, you don't see so much of callus. So basically, it's the non-union leading to implant failure.
Yes.
Okay. What was done?
Had done implant removal, sir,
Ah.
and open reduction, internal fixation with long PFN and 10-hole recount plate was applied, sir.
Okay. Okay. Recon plate.
Yes, sir.
Recon plate doesn't have any. This one, it doesn't have any hole. Who has done? You. Okay. No. But see, femur recon plate they don't go together. Put a DCP. DCP, it doesn't matter. Single blows or DCP. This is very flexible, isn't it? Still, you should have proper plate. Okay. Go on.
52 years old, 52 years old female with 3 years 7 months old, closed supracondylar fracture of right femur and closed distal third both bone fracture of right leg with implant introduced, sir. It was done in some other hospital, sir. The patient came with complaints of pain and swelling in the right knee, sir. We have already done knee aspiration twice, sir. But still, but still the swelling did not subside, and the patient had flexion up to 15 degrees, sir. So we have removed only the femoral plate.
So what's the reason for knee pain? Go back. What's the reason?
And the knee is going to valgum, sir. Early osteoarthritic changes.
There are OA changes. Probably this plate may be too close to the tibia. Okay, digging in. Okay, gone. Next. All done.
Good morning, sir. Experimentation of Unit 2, sir. 70-year-old female with intertrochanteric fracture of left femur, sir. It's a Boyden Griffin type 2, sir. We have done close reduction, internal fixation with proximal femoral nailings.
Okay.
Only one case.
Only one case.
Yes.
How many cases are pending?
3, sir.
I think this also we said review of all PF and how many are failing, how many are uniting. Now you can do it, Manoj. So probably last few years we can see till maybe 6 months or 1 year follow-up, we can see how many are. We don't know whether they are uniting or they're coming back. Data. So many will be there. Every week there's so many. We can get easily 500-600 cases in 6 months. So it's a good number. Good number.